Okay, you can just put it on slideshow and begin. Proceed.
Good afternoon, everyone. Today, our topic is the management of the aggressive patient, and it's going to be presented by myself, Hawa Bibi Kesmod, and my two colleagues, Farzana Daya and Barsha Banabas. I'll just try to go to the next slide.
It's your left corner.
Sorry. Okay. All right. So we started with the definition of aggression, and it's a feeling of anger or antipathy resulting in a hostile or violent behavior with a readiness to attack front. So aggression is a type of behavior that's intending to cause physical or mental harm. Also, aggression is an overt, often harmful social interaction with the intention of inflicting damage upon another individual. So the aggressive patient usually presents as a danger to others, as a danger to property, and to themselves. It may also occur reactively or without provocation. So aggression could occur in any setting. So in our outpatient departments, in our wards, on the hospital grounds, as well as in our community outpatient clinics. So therefore, the policy applies to all these situations accordingly. It's classified into direct and indirect aggression. And today we will be focusing on the former, which is characterized by physical or verbal behavior that's intended to cause harm. But it's also important to note that everyone can become aggressive at times. However, in the setting of other physical symptoms, aggression can sometimes be a representative of an illness, and that's what we are going to elaborate on further. So I'm on slide 2, which are the possible causes of aggression. And before I begin with some of the causes of aggression, I just want to that there might not always be a medical or psychological cause of aggression. Keeping in mind that in our hospital or COPC settings, a lot of our patients have long waiting times. Sometimes, there's misconduct from staff, which results in anger, frustration, and sometimes aggression. So some people also have a fear of hospitals and medical procedures, which could result in aggression. Of course, we have to take out the possibility of an underlying anxiety as well. Sorry, let me just, yeah. So now that we're looking at the possible causes of aggression, we've broken it up. So if we're looking at the medical causes of aggression, we've broken it up into two categories. So those conditions that, cause delirium and subsequently aggression, and those that cause dementia. So if we're looking at some of the causes of delirium, it's your hypoxemia. So of course, with decreased perfusion, we get the confusion, which can lead to the aggression. We also get some so you also have metabolic causes. And there's certain imbalances also of electrolytes and hormones which can lead to in behavior and therefore aggression. I was reading actually something yesterday, a study yesterday, which was, just highlighting one of the metabolic causes of aggression. And they were talking about, in the hyperglycemic patient or in a DKA patient, because of the confusion, they do witness aggression at times. Also, we all know that severe infection is on the top of the list for causes of confusion and aggression. And then also in the post-ictal patient, aggression as well. And then renal and organ failure can also lead to aggression. So all of these above listed conditions cause a clouding of consciousness. There's diminished comprehension, there's anxiety as to what's going on, also there's perplexity and delusion of persecution, which ultimately results in aggression. And then we're going on to the second medical cause, which is, and that's dementia. So there's a breakdown of certain parts of the brain, and it's usually due to aging or genetic disease. And this can lead to changes in behavior and also can lead to aggression. So any cerebral damage leading to decreased control can result in aggression. We're going to move to the next possible cause of aggression, and that's psychiatric. And it's actually quite a big category. And there's quite a few points listed under the psychiatric section. So we'll try to get through them. We'll just briefly elaborate on a few of them. So if you're looking at the first one, the borderline personality disorder. So this disorder usually manifests during childhood and adolescence, and it features unstable moods and behavior. So, and we also see aggression in these patients. And then, of course, psychosis. We know that's one of the obvious causes of aggression. With developmental disorders like intellectual disability and autistic spectrum disorder, we also see aggression in these patients. In the hypomanic or manic patients, they become angry and hostile if obstructed, and therefore that's why they become aggressive as well. One of the important ones is schizophrenic patients. So these patients become aggressive because of these delusional beliefs, and also, in a response to their auditory hallucinations, things that they're hearing that are not there, of course. And a good example of this is the catatonic type. So there's outbursts of overactivity and aggressive behavior is seen. And then lastly on the list is severe anxiety. And once again, I'm just going to share something that I've read. They said that in people with OCD, a lot of the time there's an underlying anxiety. And so they see aggression as well in these OCD patients. Moving on to substance use and withdrawal. We all that high doses of alcohol and drugs or medications even may lead to psychosis and aggression. And also withdrawal from these can cause similar symptoms. The next category is the psychological causes of aggression. So the first point is the people who are hypersensitive to reaction or insult. So if you tell them anything, you're going to get them being aggressive, basically. And then poor frustration tolerance goes back to when I mentioned, about our settings and the long queues and so on. And so sometimes these patients just have a poor frustration tolerance. And then we're also looking at people with maladaptive coping skills. And so the last category then is trauma. So with trauma, we have your traumatic brain injuries, and also we have post-traumatic stress disorder. And in traumatic stress disorder, aggression is seen in these patients because they experience stress and fear from small triggers long after the traumatic incident has occurred. So going on to the next slide, we're looking at some positive predictors of. So I know some of you might not agree with my first point because I've put the male gender. There's, I've read a lot of studies, and some say, aggression is, we see it in both, male and female, and there's no, it's not more commonly occurring in males. However, I read something stated that because of the testosterone levels in males, they do become more aggressive. And they gave a nice example stating that in the animal kingdom, you know, when a male is on heat, there's a high levels of testosterone, and very often we witness how aggressive they are during this time. And then also a prior history of violence, you know, is a predictor of aggression. And then we've covered the psychiatric illnesses, and lastly, you know, your drug or ethanol abuse. Thank you so much.
Good afternoon, everyone. So my name is Farazana, and I'll be speaking on the middle half of the presentation. So in our healthcare setting, we often see patients who are aggressive, and us as interns are usually first line when dealing with patients. So it is important to remember that when dealing with an aggressive patient, the primary objective is to de-escalate the situation and prevent harm to the patient, so to the aggressive patient, as well as to the other patients in the vicinity, as well as to any healthcare workers that are present. To achieve this, certain measures need to be in place, or a protocol needs to be followed. The healthcare setting also needs to have the correct equipment, medication available, as well as the appropriate number of staff members, as this factors help to de-escalate the situation and to ensure calm in the healthcare setting. So by following guidelines that are available, this will help ease the situation. So firstly, we want to try to prevent the situation. So, you know, as you drive into the hospital and there are always signs saying like no arms, patient should not be entering with any guns or weapons and that. So that's like at point of entry where the first step of the guidelines are already in place. But in the situation that a patient comes in and rather call security to help assist with de-escalating the situation. Secondly, it is important to always remain calm when dealing with aggressive patients and to be gentle and understanding. Thirdly, know where the exit points are of the building. So if fortunate case that the situation arises where the patient becomes extremely aggressive and people's lives are at risk, we know you need to know where the exit points are of the building. Yeah. Situations, either at the clinic or hospitals, and that patients often first encounter nursing staff, or they are waiting in the queues, waiting for a doctor, waiting to be seen by a doctor. So before approaching the patient, one can use this time to observe the patient. This will allow you to preempt the situation. When approaching the patient, or if a family member is close by, try to obtain history as to the possible causes of the aggression. So one can ask questions on substance use, mental health, as well as baseline functionality. Patient history is important, as this will allow you to help find the cause of the aggression. And also, just as another point, before approaching a patient or when taking a history, at the patient's body language, and look at the patient's clothing, as well as facial expressions. This will also further help you to anticipate if the patient may become aggressive. And always treat the patient with understanding and gentleness. So by obtaining information, by speaking to the patient and just looking at the patient in general, you may be able to find any triggers, whether it be physical or emotional, that may cause the patient to become aggressive.
Sorry, Pat, can you just give us 1 second?
So we are in the healthcare setting, and now we are encountering the aggressive patient. So there are 3 methods that can be followed to help resolve in order to assist you with dealing with an aggressive patient. So the 3 methods are physical restraints can be used, and secondly, seclusion is another method where a patient is placed in a quiet room. I'll further elaborate on this just now. And thirdly, chemical or medical restraints can be used. It is important to know method has its own advantages and disadvantages, and this will be discussed in the following slides. So looking at physical restraints can be used, but it should be used as a last resort to protect the patient, to protect others from the aggressive patient, the healthcare worker present. When using physical restraints, it should be used for the shortest amount of time. And the method of restraint is that, so basically 5 people need to be present. 1 person needs to be at the patient's head, and 4 other members need to be at each limb of the patient. Minimal force must be used while restraining the patient, as well as it should be done quickly and with no harm to the patient. So some of the disadvantages of using physical restraints on a patient is that firstly, it's dehydration. So because the patient is restrained, they're unable to sit up, move around, grab a glass of water. And they are completely dependent on either a nursing staff member or a doctor to provide fluids for them. Secondly, restraints are too tightly placed on the arms and the legs. This may cause reduced tissue perfusion, and it also may, especially if the patient starts fighting and becomes agitated while being restrained, and it could also lead to fractures of the limbs. So as I mentioned earlier, seclusion is another method of dealing with the patient. So basically what this entails is that a patient is placed alone in a quiet room. So firstly, this places distance between the aggressive patient and other patients. Secondly, there's a decreased chance of the patient of hurting themselves or others. And thirdly, by being alone in a there is a decreased sensory input. So this is especially important in patients whose aggressive behavior is exacerbated by external stimuli. However, the one disadvantage of the method of seclusion is that in our public healthcare setting, there may not be a quiet empty room available. Method may not always be feasible. So the Mental Health Care Act also has regulations with regards to physical restraints. So just briefly, The Mental Healthcare Act states that physical restraints should only be used or are only permissible. Other methods of restraints fail. So other medical or verbal restraints. It should never be used as a form of punishment. Patients who are physically restrained need to be continuously monitored. As I mentioned, some of the risk factors are, like I mentioned previously, is like dehydration or decreased tissue perfusion. It should not be used longer than necessary, and it cannot be used for patients who are under the age of 12. In the case of the patient of 12, a medical or chemical restraints may be used. And it's also important if a patient is being physical restrained and family members are present. Once you've done restraining the patient, always go and tell them, explain to them why the patient had to be restrained. Yeah.
All right, so moving from physical ways of restraint to more of the medically related ways of restraints. So chemical restraints are preferred over physical for many reasons. It maintains patient dignity with the specific classes of drugs that you use. They have differing onsets of actions and durations. So you're more free to cater to your specific contextual needs at the time. So of course, to start off with, assessing the patient's age, their comorbidities, likely cause of the aggression, and the current clinical state of the patient is important. Age and comorbidities for obvious reasons. For example, in an older patient, you might have to dose adjust, or in a patient that's already on antipsychotics or benzos, might require higher dosage to reach the desired effect. Ideally, it's usually a single dosage to achieve what you need to. It's vital to reassess the patient between each dosage to assess vitals, their stability, and whether or not they are still sedated or if they're breathing. And then also, I think in any primary healthcare setting specifically, oral preparation is usually the preferred route. However, in managing an aggressive patient, it's not always ideal. I'm sure most of us would struggle with getting in an IV line in someone that's aggressive, especially when a patient is blatantly refusing any sort of treatment. So briefly, through the couple of medical classes of drugs available to us are the benzos and the antipsychotics. So the benzodiazepines, the short-acting and long-term acting drugs, which we'll go through in the next couple of slides. So we've put the oral and the IM dosing anti-benzos here on this slide, just to have a brief idea. I'm not going to go through every single one of them. Those are the benzos. So you can use short-acting, intermediate, and long-term and long-acting. Antipsychotics, suggest Ritalol and promethazine. IMI preferred again over oral for aggressive patients specifically. And we'll go into the pharmacodynamics of those as well. And then post-sedation, like I mentioned, to reassess the patient's clinical stability, monitor the vitals always, especially with using benzos. And as Frazana just mentioned, just to keep the family updated through the entire thing. It might not always be easy, but just to try and be as openly communicative as possible. All right, so just briefly through some of the pharmacodynamics, I think this is really important because it's obviously, I mean, in an emergency situation or in a situation where violence is involved, it's to tailor your choice of drugs to what you have. Neither is it easy to pick something that's actually available in the clinic at that time. But I think it's important to know because drugs have a certain onset of action, duration of action, and that can really influence what you're giving and what you need from the patient, how you want to work the patient up, and how long you would prefer them to be a little bit more cooperative. So just looking at the benzos, we have the short-acting benzos, Valium and lorazepam, midazolam as the most rapid, and then clonazepam is intermediate. The action differs substantially. So clonazepam being the longest, 1 to 2 days. Midazolam, shortest onset, but also shortest duration. And then the other two, diazepam and lorazepam, duration of action between 1 and 3 days on average. Then with the antipsychotics, again, so haloperidol is much more rapid than promethazine. So again, if you are in a dangerous situation, or if family is helping you verbally communicate with a very aggressive patient and you don't have a lot of time on your hands, then obviously a faster onset of action would be preferred over a different kind of drug. And then both of them 4 to 6 hours on average. General side effects very, very broadly with the benzodiazepines and antipsychotics. So with the CNS, benzos, oversedation, decreased attention, rebound insomnia. The rebound insomnia, however, is more, well, in studies, more shown to be in patients that are on more chronic use of benzos and not so much acutely. And then there's obviously the risk or abuse, and then the risk of withdrawal. GIT side effects, nausea and vomiting, and then respiratory depression. Then with the antipsychotics, CNS, the SEs that we're always aware of, neuroleptic malignant syndrome, then with cardiovascular, just bradycardia and hypotension, and then GIT, hypersalivation, and vomiting. So we included a really, really brief case study, nothing in detail, just to offer a very broad approach of any aggressive, well, of an aggressive, mostly referring to an adult. So just to briefly go through this really quickly, a 28-year-old male comes into the ER. He comes in with his mom, who reports a 3-week history of strange behavior. He's been talking to himself and been overtly aggressive with his family. When asked, the patient denies this accusation. He says that his mother was attempting to kick him out of the family home. On history, there's no abilities, no history of acute illness. And on examination, clinically, the patient examines well. So you now need to approach this patient and say to this patient that there's a lot of causes for the reason, or the behavior that the mother is allegedly reporting. And because of this, you need to do some blood tests. So at this point, an aggressive patient cooperative and will probably continue that way. So he starts screaming and he starts threatening you. And then he starts threatening the safety and starts concerning other patients in the ED as well. He absolutely refuses to go to drip, nor will he allow you to approach him. So overall, just to start off, like Susanna mentioned much earlier in the presentation, be aware of the environment. What are the possible triggers of this patient? So for example, if you're talking to the patient and you're communicating to him, and if you mention his mother, maybe he suddenly becomes more angry. So then just avoid that in conversation with the patient. Stay calm, don't shout, try and de-escalate. And if you need security to help you, then it's obviously better to call them for assistance or any nursing staff. Again, you can ask for assistance with temporary physical restraint. If his mom is in the ED, like in this case, obviously communicate with her. She will obviously have a much better understanding of the reason that you need to sedate over a patient in that moment. Again, we mentioned there's likely IM, and he's not allowing to approach you. So you're going to need to try physical restraint to sedate him and then continue with a full medical workup. So then we added to communicate calmly with his parents, be as transparent as possible in the situation, followed by the physical restraint, the sedation, and then the actual. And then just to note at the end of this, while all of this is going on, it's obviously very difficult to document in an ED setting. But after everything is stable and after the patient is sedated, just to clearly document why the sedation was required, that the parent or caregiver or escort was involved, and then the intended use and duration of the medication chosen. All right, thank you so much.
Thank you very much, team. I'm going to just put a poll up because I think we need to start getting an assessment. If you can just try and fill it in while some comments are being made, this feedback will be helpful. So I just want to note or mention some things. One is that if you have a patient who is aggressive, don't always think this is a psychiatric patient. A psychiatric patient is an important consideration and understanding what type of psychiatric issue it is. But do not forget that there are organic causes for a patient to be aggressive, and be aware of these. I think there have been some gone through. I think the question of blood sugars is very important. Always do a blood sugar on a patient. It's not only hyperglycemia that can produce an aggressive patient, but a hypoglycemic patient. And that's very important to note. I think otherwise, the presentation was a useful one. I'm sure your take home is consider medical sedation and beware of the rest of the caution that you need to have in an aggressive patient. Okay, I think not everybody has voted. I'm hoping you will. I think this is feedback to the group, so please do. All right, I'm going to stop it here. Thank you very much, our BVN team. We are going to go to the next if there are no questions.